My name is Jonathan Leighton, and I am Professor of Medicine and Chair of the Division of Gastroenterology at the Mayo Clinic in Arizona. Today, I will be discussing our manuscript entitled Performance of the Patency Capsule Compared with Radiologic Examinations in Patients with Intestinal Strictures. This study was performed at the Mayo Clinic in Arizona with IRB approval. Capsule endoscopy, as you know, is a disruptive technology that has revolutionized our approach to small bowel disease. While capsule endoscopy is considered very safe and patient-friendly, there are potential contraindications and complications that are important to discuss. For example, cardiac pacemakers or other implanted electromedical devices are a current contraindication, although studies overwhelmingly suggest that the capsule in these patients is safe. Swallowing disorders are another potential relative contraindication, and in those patients who have significant difficulties, endoscopic placement may be preferable. Finally, known or suspected intestinal obstruction or strictures are also a contraindication due to the risk of capsule retention, and it is this area that our manuscript focuses on. Capsule retention due to obstruction or strictures certainly is the most feared complication of capsule endoscopy. The rate of capsule retention appears to be dependent upon the capsule endoscopy indication. For example, in patients with obscure gastrointestinal bleeding or suspected Crohn's disease, the risk appears to be relatively low at around 1.5%. On the other hand, in those with known Crohn's disease, where there is a higher incidence of strictures, the risk can vary from 5 to up to 13%. The risk in normal volunteers, as might be expected, is essentially zero. Therefore, patients with abdominal pain, distension, and nausea, or those with known Crohn's disease, should be suspected of having the potential for capsule retention. Other risk factors include anti-inflammatory drugs, abdominal radiation, and known tumors. Capsule retention has been a major concern for gastroenterologists who use the capsule endoscope. Many high-risk patients are unable to undergo the capsule study due to the risk of retention that requires endoscopic or surgical removal. Traditionally, radiologic examinations are used to risk stratify patients prior to capsule endoscopy. But unfortunately, radiologic tests have demonstrated significant inaccuracy at predicting retention. The patency capsule is another test introduced to assess the functional patency of the small bowel in patients with known or suspected intestinal strictures. But there are limited studies on its use. There are, in fact, no studies directly comparing the ability of the patency capsule and radiologic exams to detect clinically significant small bowel strictures. Hence, our study focuses on identifying the best test that can be performed to recognize patients who are at risk for capsule retention. I would like to explain how the patency capsule actually works. It was developed to reduce the risk of obstruction observed with capsule endoscopy. It is a dissolvable capsule developed to assess the functional patency of the small bowel to identify patients who can safely undergo a capsule study. The patency capsule itself is made of lactose and has 2 plugs on either end. It also contains an RFID tag in the center, which can be detected by the use of a handheld scanner. GI fluids enter into the plugs through the windows on the sides. The plugs dissolve slowly and allow entrance of fluids into the body of the capsule after 30 to 60 hours. At 30 hours, the patency capsule begins to dissolve, and it should dissolve completely somewhere between 36 and 72 hours. Once dissolved, the remnants include an empty plastic shell and the RFID tag. If the patency capsule is excreted within 30 hours of ingestion, as confirmed by the handheld scanner or an X-ray, or if the patency capsule itself is excreted intact anytime after ingestion, then patency is assumed. In our study, the aim was to compare the patency capsule and radiologic exams, including cross-sectional imaging and small bowel follow-through, to detect clinically significant small bowel strictures. the main outcome measures are sensitivity, specificity, positive and negative predictive values of the patency capsule, and the radiologic tests for detecting significant strictures. We retrospectively evaluated 42 patients who underwent the patency capsule, as well as radiologic tests within 3 months of the patency capsule and capsule endoscopy. As previously stated, we then estimated and compared the sensitivity, specificity, positive and negative predictive values, and receiver operating characteristic curves of the patency capsule and the radiologic exams for detecting clinically significant strictures. We considered surgery and/or successful passage of the capsule as the gold standard. In terms of the results in our study, both the patency capsule and the radiology exams showed similar sensitivity and specificity. The ROC curve of 0.71 for the patency capsule suggested that its overall ability to discriminate between a patent small bowel and one that was obstructed was very reasonable. Also, the negative predictive value for the patency capsule and radiologic tests was not significantly different, suggesting that if either test is negative prior to ingestion of the actual capsule endoscope, the patient will most likely pass the capsule with no retention. In our study, it is also worth emphasizing that the combination of both the patency capsule and the radiology test had the highest sensitivity of 100% for identifying patients with significant strictures. During our study, we also recognized some issues with the patency capsule that I would like to emphasize. False positive results did occur in 5 patency capsule exams. All false positive patency capsule patients had negative CT enterography and successfully completed the actual capsule endoscopy study. We also learned something new from this study. A limited non-contrast CT demonstrated the patency capsule to actually be located within the colon in 2 of these 5 patients, where the handheld scanner detected the RFID tag. Our belief is that in a subgroup of patients with slow colonic transit, although the patency capsule actually passed through the small bowel, the RFID tag was still present at 30 hours based on the scanner and would infer a non-patent small bowel. Unfortunately, plain films of the abdomen do not accurately localize the patency capsule or the RFID tag. In our experience, a limited CT of the abdomen is a more definitive method of localization, and this will eliminate the problem of false positive patency capsule results. Otherwise, many patients who would benefit from a capsule endoscope study may be unnecessarily excluded. We also noticed significant strictures that were missed by both the patency capsule in 3 patients and the radiology tests in 2 patients. The cause for the false negative tests is not entirely clear. The false negative tests may be due to the time interval between the patency capsule, the radiologic test, and the actual capsule study and surgery, which was up to 6 weeks to 6 months in this study in some of the patients. This certainly requires further investigation. In any case, our results suggest that the negative predictive value for the patency capsule and radiology tests were not significantly different, suggesting that if either test is negative prior to capsule endoscopy, the patient will most likely pass the capsule without incident. In addition, a limited CT of the abdomen can be used to minimize patency capsule false positives by confirming or excluding the presence of a significant stricture suspected by the patency capsule, and also to localize the patency capsule in the colon if delayed passage is identified by the handheld scanner. We believe that the majority of patients with suspected or definite small bowel strictures or obstruction can undergo capsule endoscopy safely if the patency capsule passes by 30 hours. Our results also suggest that in high-risk surgical patients, it may be prudent to also perform cross-sectional imaging even after a negative patency capsule in order to minimize the risk of missing a significant stricture. Conversely, even if the radiologic exam is negative in these patients, a patency capsule exam should still be considered to confidently exclude a significant stricture. We believe, based on our experience thus far, that radiologic tests are complementary and not a replacement test for the patency capsule in patients with suspected clinically significant strictures. In addition, if the RFID tag is detected after 30 hours, we recommend a limited non-contrast CT to be performed to determine if the RFID tag is indeed in the colon, allowing the patient to proceed to capsule endoscopy. Of course, larger prospective studies are necessary to evaluate the efficacy and safety of the patency capsule. We do feel strongly that prospective studies are needed. As a result, our plan at this time is to study the patency capsule prospectively, comparing its ability to predict the presence of a stricture to that of CT or MR enterography. We are hopeful that this will provide additional useful information and look forward to reporting that data in the near future. I would like to thank the editors of Gastrointestinal Endoscopy for allowing an opportunity to share our clinical experience with others in the gastroenterology community on this important topic. Thank you.